Good morning, ladies and gentlemen. I am Haja Nawazish Ali, a third-year MBBS student at Central Park Medical College.
And my name is Muhammad Ali Arshad, and I'm a first-year medical student at Central Park Medical College, Lahore. It is our pleasure to be your hosts for the CTD session today.
To chair this session, we are pleased to invite Professor Kamran Cheema, Head of Department of Pulmonology at Gulab Devi Hospital, Lahore, and Professor Wajahat Aziz, Professor Javed Malik, the two former presidents of Pakistan Society of Rheumatology.
Along with Dr. Sabah Saif, consultant rheumatologist at CMH Lahore, as the co-chair of the session. May I request our esteemed chairs to kindly join us on stage.
Our first keynote speaker for this session is Professor Chris Denton, Professor of Experimental Rheumatology, Consultant Rheumatologist, and Joint Director of the Center for Rheumatology at UCL Medical School and Royal Free Hospital, United Kingdom. Today, he will be presenting on making progress in heart disease, current and emerging therapies for systemic sclerosis.
This session promises to provide valuable insights into the latest therapeutic advances, helping clinicians navigate the challenges of managing this complex disease. Please join me in warmly welcoming Professor Chris Denton to the stage.
Thank you very much. And I'd really like to thank the Pakistan Society for Rheumatology for this invitation. It's a great honor to be here, and I'm really learning a lot from this fantastic meeting about rheumatology in general, and also obviously rheumatology specifically in Pakistan. So I look after a large cohort of patients, more than 1,500 patients with systemic sclerosis at the Royal Free Hospital in London. And what I want to share with you really is some of the progress that's been made in managing this difficult condition over the last 2 or 3 decades. Here are my disclosures. So what I will do, I will review the clinical challenge or burden of systemic sclerosis, how we have now much better evidence-based treatment and treatment recommendations and guidelines, and just review some of the recent trial results, and also perhaps look a little bit to the future of where we might be going and hopefully get more progress in years to come. But systemic sclerosis does remain a very challenging condition. It's a rare condition. It affects 1 in 10,000 in the UK approximately. It has a peak onset in what I would regard as the prime adult years, between 30 and 60. It's a female predominant disease, but if you do get it and you're a man, you often have a worse outcome. And despite the progress that I'm going to share with you, it's still a disease that half of the patients that are diagnosed with it in our cohort do ultimately die as a result of it, even though they are now living considerably longer with the condition. So you can classify the disease traditionally into those who have extensive skin hardening or sclerosis with diffuse cutaneous disease. That's about 1/3 of the patients, and the other 2/3 that have less extensive skin sclerosis. But the important thing to remember is that this is truly a multi-system disease, and in whichever subset you're in, you can get any of the major complications of the disease, which are summarized here. And I think traditionally we have focused on the life-threatening complications of heart, lung, and kidney involvement, and of course that's appropriate. But it's also very important to remember that for our patients, the thing that really bothers them is what we might term the non-lethal morbidity of the disease. The digital vasculopathy, the severe gut symptoms, the impact on hand function through contractures, calcinosis, and digital ulcers. So this is something that troubles them every day, and we really need to be thinking about managing that part of the disease as well as the important organ-based complications. But it's undoubtedly one of the advances that's happened in the last few decades has been the appreciation that we really shouldn't wait for things to happen in systemic sclerosis. We should try to be proactive. And I think it's important that every patient with systemic sclerosis, once they're diagnosed, they have a systematic set of investigations, and then those investigations are repeated. So at least once a year, as we follow up our patients, we are considering whether they might have developed interstitial lung disease, whether they might have pulmonary hypertension or pulmonary arterial hypertension, whether they have severe gut disease, whether they're at risk or have got renal problems, and of course, whether they might have cardiac involvement. And in our patients, one of the big challenges is to diagnose what is primary systemic sclerosis heart disease from cardiovascular comorbidity, although of course the two are probably equally important in treating patients. So there's no doubt that regular screening of patients has improved outcomes, and I think it's shown by this analysis, which comes from our centre at the Royal Free. So we looked in quite a simple way at new systemic sclerosis patients presenting over a 4-year time period in the early 1990s and then a decade later in the early 2000s. And what you can see is that there's been a significant improvement in 5-year survival from less than 70%, which was typical of the era back in the sort of 1980s, up to 84% 5-year survival. So a significant improvement for diffuse scleroderma and also for limited disease. Now, one of the things we think that has helped with that has been the regular screening, because when we look at the frequency and diagnosis of major lung complications, it's much more in the modern era. So it looks like the disease is worse, but the patient's doing better because we're treating them. The other change that in our centre came in around 2000 was that all of the diffuse patients are routinely started on mycophenolate mofetil. And as you'll see, I think this is a very important drug for improving outcome in the disease. So those two subsets do help us a little bit to predict what problems might lie ahead in managing patients. You can see here, again, around 700 patients from our cohort followed out for 15 years. It gives you a feeling for the timing and frequency of those major complications. You can see that 50%, about half of the patients with diffuse scleroderma will ultimately get lung fibrosis, whereas about 1 in 4 of the patients with limited scleroderma, of course, this is a commoner subset. If you look at the red line, that's pulmonary hypertension, you can see it's equally frequent in the two subsets, and the longer you have the disease, the higher the risk of developing that complication. But the skin subsets don't really give us the sort of level of information that we really would like, and I think that one of the other advances that's happened in the last few years is an appreciation that the autoantibodies we use to diagnose systemic sclerosis are also very useful in risk stratification, in predicting the future for our patients. So I've shown in this panel some of the major antibodies. Most patients with systemic sclerosis will have one of these, but they will have only one. They're mutually exclusive. Typically, they will have an anti-centromer antibody, an anti-SCL70 antibody, and in our population, an anti-RNA polymerase 3 antibody is the third frequent antibody that we see, but others occur. What's interesting is those antibodies do associate with different long-term survival, but if you look at specific complications, they become even more useful. So you can see here, for scleroderma renal crisis, you have a 10 times increased risk if you have the anti-RNA polymerase 3 antibody. Conversely, if we look at lung complications, you can see that for early interstitial lung disease, the risk is very, very high if you have anti-SCL70, and this is independent of skin subsets, so even limited patients have that same high risk, and it tends to be the early lung fibrosis occurring in the first 3 to 6 years. Conversely, for pulmonary hypertension, the anti-U3-RNP antibody, fibrilarin, is very strongly associated with earlier pulmonary arterial hypertension. Other antibodies like anti-centromere are associated with later stage PAH. So we can use the skin and the autoantibody profile at diagnosis to help us predict the future for a patient. And this is very important, I think, for management. So I just want to highlight the updated 2024 BSR guideline for the management of systemic sclerosis. This is freely available online as a QR code that takes you to a full text reprint. And this complements other recommendations from EULAR and other organizations, but this was really designed, and I led the group of another 29 experts and patients from the UK and Europe to develop what we think is a roadmap for the management of systemic sclerosis with expert and evidence-based guidance. And it just highlights the principles of early diagnosis, of stratification I've talked about using skin score and skin subsetted autoantibody, baseline investigation, and then systematic investigation and follow-up so that the complications can be treated. And what I can say from these guidelines is that we can now say that systemic sclerosis is not an untreatable condition. And here's another figure from the guideline just showing for each of those different manifestations, there are treatments with different levels of evidence and different levels of efficacy. But at least we can now treat complications, including those that are flagged up in red as the life-threatening complications of the disease. So I just wanted to think in a little bit more detail about some of those treatments. And first to start off with skin disease. So the cornerstone really of diffuse cutaneous systemic sclerosis is the management of the skin. It's what the patient first presents with typically. And as rheumatologists, we've been very familiar in the context of this autoimmune disease of using immunosuppression, and I put the drugs up here that are in routine use, and these are all considered in our guidelines and also in those from EULAR. So we have simple lower intensity immunosuppressants such as mycophenolate and methotrexate. We have rituximab, cyclophosphamide, and for those patients that are particularly severe, we may use very intense approaches such as autologous stem cell transplantation. So we do now have quite good evidence that these drugs are very helpful, and as I said, I think they're an important aspect of improved outcome. So interestingly, for mycophenolate mofetil, there's never been a randomized controlled trial of that drug, but there has been information coming from other clinical trials. And I just highlight some data from a post hoc analysis that I undertook with Rob Spira from the United States of the Resolve-1 data set. This was the largest clinical trial ever conducted in diffuse systemic sclerosis. Recruited 375 patients. Unfortunately, it was a negative trial in that the drug linabecim didn't outperform the standard of care therapy. And one of the reasons for that may be that the standard of care therapy for the majority of patients in this study was mycophenolate mofetil. And what you can see in this post-hoc analysis was a comparison of those different immunosuppressive drugs or patients that weren't on immunosuppression. And you can see that if you were on mycophenolate mofetil in this study over 1 year, you had a tremendous improvement in skin score and you had a preservation of lung function. Whereas if you were on, had no immunosuppression, you had a much lower improvement in skin score, and in particular, you lost significant lung volume over the first year of your follow-up. So I think that gives us very good support for our approach. But of course, those low-intensity approaches are not sufficient, and some patients do need more, and that's driven us to try and get better treatments we can add to mycophenolate. And the gold standard that shows us perhaps what can be achieved is autologous stem cell transplantation. This is a challenging treatment. Basically, it's giving a non-survivable myeloablative immunosuppressive chemotherapy regime with radiotherapy and antithymocyte globulin in some cases. So it's non-survivable unless you have an infusion of your own stem cells that were previously harvested that allow you to reconstitute a bone marrow. But interestingly, this very intensive treatment has been shown in 3 randomized trials to be superior to treatment with cyclophosphamide over 1 year, so not itself a trivial treatment. And just to show you for the 2 main trials, this is the ASTIS trial from Europe and the SCOT trial from North America, what you can see is the long-term survival and event-free survival is much better if you have a stem cell transplant than if you have 1 year of cyclophosphamide. But I would highlight that that advantage only occurs at around 2 years. That's, you get this long-term advantage, but up to 2 years, it's not clear that the stem cell transplant has given you a big advantage, even though you see the dramatic improvements in the short term in skin and musculoskeletal symptoms. And the reason for that is because it's a hazardous treatment. So what we'd like to do is try to achieve the level of benefit from a stem cell transplant, but with the intensity of mycophenolate, perhaps adding on other drugs. And I'm just going to share with you the results of some of the recent trials that have helped us move in that direction. I'm going to talk about nintedanib, tocilizumab, rituximab, and just introduce perhaps the future of where we might be going with some cellular therapies. So nintedanib, as you may know, is an antifibrotic drug that was approved for idiopathic pulmonary fibrosis, a much more progressive, severe form of lung fibrosis. But the question that was obvious to ask was whether this would also be effective in systemic sclerosis-associated interstitial lung disease. So the Census trial recruited nearly 600 patients. We were a big part of that. We were a top global recruiter in our center. And we were very pleased to see the results that the trial met its primary endpoint in that if you were on nintedanib, you had lower decline in lung function over a year than if you were on placebo. And this was about a 44% reduction in progression, so quite comparable to what's seen in IPF. But fortunately, this was a pragmatic study that allowed you to be on background immunosuppression, and fortunately, 50% of the cohort were on background MMF. So this gives us another chance to look and see what's the benefit of mycophenolate mofetil, this time on SSc-ILD. And what you can see in this post hoc analysis that we subsequently published in Lancet Respiratory Medicine, that it really shows that if you were on no treatment at all, you have 120 mils loss of lung function in a year. If you're on either MMF or nintedanib alone, that's halved to about 60. If you're on both, it's only 40 mils per minute, which is not much above physiological loss of lung function over a year. So what the mycophenolate essentially does is it moves those curves upwards, so you get added value. And again, to try and understand that better, to get full value from this very important and large study, in conjunction with Nicole Goh and Athol Wells from the Brompton in London, we looked in detail to see if we could dissect out which patients were particularly responding to MMF. And if you just look at the heat maps, the contour plots at the bottom of this slide, what you can see in the placebo arm, so no nintedanib, there was certainly attenuation of progression, particularly in those patients with less extensive lung fibrosis with the MMF, suggesting maybe it's targeting the earlier or milder forms of lung fibrosis, whereas on the right, you can see nintedanib starts to really attenuate the more progressive disease. And when you're on both drugs, you've really got a very good response. You've lost that relationship, you can see in the upper panel, between the severity of lung fibrosis and the rate of progression over a year. So you've really modified the process. But I showed you that some patients get very early progressive lung fibrosis, particularly in diffuse scleroderma. And what we noticed a few years ago is that many of those have a high acute phase response, a high ESR, and we went on and showed they had a high level of IL-6, a driver of the acute phase response. And interestingly, those patients that had high IL-6 levels, even in this small cohort of just 40 patients, showed a significantly worse long-term survival. So we thought maybe targeting IL-6 in these high-risk patients could be very helpful. So we went to Genentech Roche, who have the marketing authorization globally for tocilizumab, blocking IL-6 receptor. And we thought maybe we could do a clinical trial, but in fact they were so impressed with the idea that they funded 2 large clinical trials, a phase 2 and a phase 3 clinical trial. And we were very pleased to see that our hypothesis was correct, because if you go on to tocilizumab and you have early diffuse systemic sclerosis with this high acute phase response, you have a dramatic benefit on lung function. You can see you stabilize the progression of lung function and loss of lung volume over a year compared to those in the blue line, which is the true placebo patients on no immunosuppression. If you look at the subgroup, about 2/3 of those patients have lung fibrosis evident on their baseline CT scan. It's even more dramatic. You save about 250 mils of lung volume over a year. But what was very interesting when we again did a further post-hoc analysis to truly understand treatment response better, the patients who really drive this are in fact male patients, but also those with anti-SCL70. So if you have that antibody that associates with a high risk of early lung fibrosis in SSC, those are the patients that are responding to tocilizumab. So what about other drugs? Well, rituximab, we're familiar with in rheumatology. There was a clinical trial in Japan, a small study, the DESIRES trial. This showed a significant benefit in favor of rituximab compared to placebo in quite a mixed cohort of patients, benefit for skin and for interstitial lung disease. And that benefit for SSc-ILD was confirmed in the RECITAL trial that was led by Toby Mayer in the UK. So the RECITAL trial was an CTD-ILD trial, but it contained a significant number of 40 systemic sclerosis patients. And when we looked at the systemic sclerosis patients, as for the whole cohort, it showed that one course of rituximab, 2 grams, was as effective as 6 months of IV cyclophosphamide. But for the systemic sclerosis patients, there was a significant benefit for skin that was not seen in cyclophosphamide for the rituximab. So we really confirmed the Japanese study. So there's been a lot of progress in the last few years. I've shown you the data for census that's led to approval of nintedanib for interstitial lung disease, the trials of tocilizumab, an FDA-approved drug now, and the DESIRES trial led to approval in Japan of rituximab. There have also been positive studies, phase 2 trials of other drugs targeting pathways that may be followed up. But I'd just like to finish by perhaps looking a little bit to the future. We've heard this in the previous session, a little bit about the fact that cellular therapies may be very effective. So in refractory lupus, it looks very encouraging that deep depletion of B cells using CD19 targeted CAR T cells can really be helpful in difficult patients. So CAR treatment is chimeric antigen receptor, so it's a molecular receptor that's engineered to make that you can make your own population of T cells that will recognize whatever you want, but in this case, CD19 positive B cells. And when you do that, it's certainly shown positive results in a number of autoimmune diseases, but in systemic sclerosis, second and third generation trials, therapies were used, and there's been a series of 6 patients treated with a second generation CAR T that looks encouraging. So the future really is how this cellular approach to therapy could be used and how it might evolve even beyond just targeting CD19 cells. Maybe you could target other immune cells, fibroblasts, etc. So what I'm going to finish with is to say that systemic sclerosis remains a major challenge. We are doing better, but there's a long way to go. I think the trials are also improving, as I showed you, some of the understanding of pathogenesis. But just a reminder, because our patients insist that we really don't forget it, the non-lethal burden is still tremendous, and as mortality improves, living with systemic sclerosis becomes a bigger challenge. So I'd like to just thank our patients at the Royal Free and our research funders, and that again is the QR code for the BSR guideline. And thank you very much for your attention.
Thank you, Professor Chris Denton, for such an insightful talk. I would request our expert panelist, Professor Irfan Malik, Head of Department of Pulmonology at University College of Medicine and Dentistry, Lahore, to please join us on stage.
Our next speaker is Dr. Shakaib Sajid Qureshi, Consultant Rheumatologist at IMC Lahore. Dr. Qureshi is an experienced rheumatologist with a deep interest in diagnosing and managing complex neuromuscular and autoimmune conditions.
Today, he will be presenting on Not All Weaknesses as Myositis, Sorting the Mimics with Confidence. Please join me in warmly welcoming Dr. Shakaib Sajid Qureshi to the stage.
Assalamu alaikum. I'll try to keep this talk a very light kind of a talk, no high-powered stats typically, and a few slides here and there for just a few light moments. This is who I am. Most of the people probably know me now. So first of all, in order to tell about the mimics, I'll first briefly just refresh Sjögren memories about what is myositis. So as we all know, myositis is an autoimmune inflammatory group of diseases which now are more systemic rather than just muscle. We know that the muscle can be involved, but there are a few subsets where the muscle may completely be not involved, but they're systemically very important. Now the diagnosis of autoimmune myositis is antibody-based as compared to the previous paradigm where we used to have just polymyositis, dermatomyositis, and then muscle biopsy and EMG. So it's very much driven by the myositis-specific antibodies. And extra muscular features are very important. So this is just I think you must have seen this many times. I like it a lot because it gives you a very clear-cut kind of a classification which is currently available based on the autoantibodies. As you can see that in this diagram, almost everybody, like every kind of a syndrome has an underlying autoantibody presentation. In antisynthetase syndrome, you can see the mechanics hands, Raynaud's phenomena, arthritis, and typically they can have lung disease too. And then there is the devastating MDA5 antibody, which can cause very severe lung disease. The skin disease has, the skin component is SAEMI2. Then there is the malignancy, severe myopathy, the necrotizing myopathy we know. is SRP and HMGCR. And then there is a group of overlap and IBM. There's a video actually, I don't know whether I should have presented it or not, but if it does run, it's a little bit of a, oh, it didn't do anything. Okay, anyway. So we tried to actually download a video. I don't know whether it can run or not. It's about the mimics. So how the, just to make a fun video. How many people know about Javed?
Very naughty.
अच्छा एक होता है एक आवाज निकलना आप तो आपकी तो शक्ल भी वैसी बन जाती है
हाँ मुझे वो आदत है
ना
हाँ जैसे मुझे अगर जावेद अख्तर बनना है तो मैं शक्ल मेरी वैसी बन जाती है
यार एक बार मेरा फेवरेट
People know about Javed Akhtar साहब.
कुछ बोलने
आपको किसी व्यक्ति को अगर समझना है तो आई वुड रेकमेंड कि आप उसके साथ 14 बरस रहिए या उसको एक बार आप गुस्से में देख लीजिए That time you will come to know what is the person about, the personality and the trait of that person. तो वो आ जाता अपने आप.
मतलब ठीक है मुझे लगता है कि आप शक्ल वैसी बनाते हो आवाज ऑटोमेटिक वैसे निकलती है क्या
हाँ वो हो सकता है
फिर से एक बारी
हाँ
शक्ल एक बार फिर से
very naughty.
Just because of the fact, just to show how things can mimic each other, you know. Just a light-hearted moment. I thought after the 2 days of high-powered talks, and how do we move forward? So this is a diagram of the skeletal muscle. You can see the skeletal muscle, you can see the epimysium, you can see the muscle fascicles, myofibrils, and endomysium, perimysium. Why it is important is when the true myositis hits, the histology is very important. And in histology, where the inflammatory cells are, endomysium, perimysium, this was always very confusing to most of the people because we just memorize them. We don't know the structure of the muscle. So that's why I put it there. Now we start the mimics, the things that look like myositis, but they're not myositis. So in that, I think the most important is the statins. As we all know that statins are very widely used. As you can see in this, the stats from US from 2009 to 2019, how much the usage has grown up, you know, from 31 million to 92 million people are potentially using statins. In fact, when you're more than 40 years of age, 44% of the patients are potentially eligible to use the statins. And we all know that the statins can hurt. Hurt means that you can have little aches and pains with many statins. And when you start them, patients can start having these diffuse pains, leg pains, indescribable pains, and you end up stopping them. But then you don't know what to do. So there are 4 main categories here where the statins can can hit you and cause symptoms. So if it's simple myalgias, CPK is typically normal. It's bilaterally symmetrical, and then it's the commonest. If you stop it, everything goes away. Then there is a true myopathy, which means actual muscle damage can happen, where the CPK can be really elevated. You stop it, things still improve. But then there is a very severe phenomena where rhabdo can happen. And it can be a very painful condition, high-level massive CPK elevation, myoglobinuria, potential kidney damage. And in this case, you have to admit the patient and treat them so that they can be saved. And then we know the autoimmune myositis. I don't have to go into that detail. Probably all of you now know about it. So in order to differentiate between the statin-induced muscle injury and the true myopathy, remember these few items. So the onset in statin-induced muscle injury is weeks to months after starting the statins. In dermato or polymyositis or IMNM, it's very gradual onset typically. The CPK can just be normal, but can be truly raised also. But in the true myositis, CPK is typically very high. And response to the statin cessation, if you stop the statins, if it's not an autoimmune phenomena, things go back to normal. Whereas in true myositis, you have to treat the patient in order to bring the CPK level down. So autoantibodies are negative in statin-induced routine myopathy, and in the autoimmune process, you'll find the autoantibodies. MRI can be normal in statin-induced muscle injury. Autoantibodies are mostly positive in case of the true myositis. And then the other systemic symptoms can be present in case of autoimmune myositis, and in case of just the statin-induced muscle injury, it's just the muscle symptoms, and then they go away. Management, these are the few key points I thought will be important in your management. Typically, the highest risk of the statins are atorvastatin, simvastatin, and lovastatin. And whenever that happens, like you feel that the patient has symptoms, the statin-induced muscle symptoms, then another safer bet is to stop those high-risk statins and try like a low dose of a safer statin. So safer statins are pravastatin or rosuvastatin. Another way that you can deal with them is try to use alternate day dosing. Alternate day dosing means that studies have also shown that if you use the statins every other day, many a times you can still achieve your purpose of lowering your cholesterol to a level which is suitable. Now, if a true autoantibody-induced statin damage has happened, where your antibody phenomena is there, then you cannot use the statins, as we all know. So in that case, the best drug to use are PCSK9 inhibitors. I don't know whether they're available in Pakistan or not yet. In US, I was able to get it approved for one of my patients recently. And they are very safe drugs. And they can really bring the level of LDL down. So another very important point to remember with statin-induced muscle symptoms is that everybody probably in this room knows about placebo effect. Does anybody knows about nocebo effect? Yes, excellent. So opposite of placebo. So placebo means that placebo is a dummy effect of where you feel that the patient even does not get the drug, they feel improvement in their symptoms. In nocebo effect, it's the opposite. That means that you already know that the drug has a negative connotation attached to it, that it's going to probably cause muscle symptoms. So now when the patient takes it, they're going to have this symptom without actually having the phenomena of muscle injury. So this, and when many a time with nocebo effect, when you stop it, start the patient again on the medication, encourage them, nothing happens. So this is a true phenomenon in case of statins. So a lot of people who are re-challenged, they do pretty good actually. The next topic actually is steroid-induced myopathy. So the first part of my talk is basically the toxins which can cause toxicity to the muscles. So steroid-induced myopathy is very important because we all know that we deal with the patients who we give steroids quite a bit. We use different kind of steroids. Some people use dexamethasone. Some people use prednisone. We use prednisolone in Pakistan. We know that there is IV solomedrol available. All kind of agents. But how this becomes a very complex situation when we have put the patient on, let's say, even on a myopathy patient on high-dose steroids, and then after 3 months, we don't know whether it's the muscle disease which is not getting better or it's the side effect of the steroids. So there are a few things which can differentiate both. So differentiation would be basically based on the EMG, the clinical condition of the patient, and then even the MRIs can be done to see whether there is an active damage going on to the muscles versus just a chronic fibrosis. So these are a few points which can help. Another very important point is that if you do the muscle biopsy, you're going to find that there will be selective atrophy of the type 2B muscles as compared to the actual autoimmune muscle damage from the underlying disease. So remember one thing, dexamethasone is the worst out of all these choices. Because in dexamethasone, you can get an acute myopathy too, as compared to the chronic long-term exposure of prednisone or prednisolone. How do you manage that? Gradually just start tapering off the steroids. If you feel that the muscle disease or underlying condition, whatever you're treating, is well treated, try to find alternate treatment options, other immunosuppressants other than steroids, and try to switch the fluorinated steroids, which is dexamethasone, to something else. And the most important part is the physical therapy and training of the muscle so that you regain your muscle mass. Next one is hydroxychloroquine. So the reason I actually picked all these things as compared to the very complicated ones was my main aim was to give you some useful points in the kind of treatments that we use all the time. So hydroxychloroquine myopathy, I think including in this room, I think at least me, I'm probably the largest prescriber of hydroxychloroquine. In Pakistan, we have limited choices. This is one of the best drugs to help methotrexate and other drugs. Along with lupus, it's the main drug. So, but in certain cases, actually, hydroxychloroquine can also cause myopathy. And it's basically are the patients who are older age patients who have kidney disease and who are on concomitant medications such as statins. So when statins are combined with hydroxychloroquine in an older age patient who has a chronic kidney disease, there is a chance that you can develop this hydroxychloroquine myopathy. To keep that in your mind. Again, the underlying mechanism is lysosomal dysfunction. In case of the lysosomal dysfunction, there is an accumulation of hydroxychloroquine in the muscle cell. It can develop after months or years. So it's basically a cumulative damage. It's not going to happen within 1 month, 2 months, 3 months. So remember, it's going to be prolonged use in an older patient with chronic kidney disease. So this is actually a diagram showing the vacuoles, which is basically the underlying way to diagnose this patient. So you can see in slide A, B, and C, you can see in A, you see one vacuole which is being shown. In the second and third, you can see multiple vacuoles. And then in the slide D, there is a filamentous kind of like actually D, E, and F. Instead of the lumpy kind of vacuoles, it can be in the slit form as well. Now, colchicine-induced myopathy. We all use colchicine too. Again, I wanted to give, again, a practical tip about colchicine. In fact, colchicine probably now has more indications than anything else. We know that it can be used in gout, acute, or chronic, but it can also be used in case of FMF. It can also be used in cardiac indications. So colchicine-induced myopathy is to also be to be kept in mind, because now we know that it can be used in heart disease quite, more than it used to be in the past. Again, the underlying process is autophagy. Autophagy, everybody probably knows that it's basically a programmed cell death. So if the programmed cell death is not happening properly, then actually the vacuoles develop, and then these vacuoles can be surrounded by a rim. So as you can see in this kind of a biopsy, it's a rimmed vacuole. So for all the students who take board exams, this is actually what they're going to present. In the colchicine myopathy, they're going to give you multiple vacuoles surrounded by a rim. Although in practical life, how many times you're going to see, we don't know. But in exam, you always remember that this is how you're going to be diagnosing the patient. So any patient on this combination, it's a high-risk triad, as you can see, colchicine plus statin plus CKD. Alcohol-induced myopathy. I've personally actually seen a patient in ICU about a while ago with acute alcohol myopathy. So acute alcohol myopathy is much more painful as compared to the chronic alcohol myopathy, which is painless. In acute alcohol myopathy, it can be pretty rapid. It can cause rhabdo. It can cause marked CPK elevation as compared to the chronic one. In chronic one, the CPK can be normal. In acute case, the LFTs are mostly deranged. In chronic, it's the chronic liver disease stigmata which are more important. So typically, in case of an acute alcohol myopathy, you admit the patient, treat them with IV fluids, correct the electrolytes, and then it's reversible by abstinence. So it's pretty quickly reversible. In case of chronic alcohol myopathy, things happen over a certain period of time, such as 10 years, 5 years, chronic alcohol use, including the binging in between. So in that case, if you do the MRI scan, you're going to find just a chronic fibrosis, chronic atrophy as compared to the acute damage. So CPK is mostly normal. So how do you do in case of a chronic alcohol myopathy? Is more difficult to treat because now you have to build the muscle mass back again. So the patient has to be put in a proper rehab program. They have to be slowly nourished again. You have to make sure that they get the thiamines, the B1, the B6, and all those supplements so that they can develop their muscle mass back again. And the ongoing damage stops. The second part of the second or third part of this talk is endocrine myopathy, hypothyroid myopathy, and then hyperthyroid. So one thing, remember, if you don't check anything else, in case of working up your myopathic patient, always run a TSH. Hypo and hyperthyroidism, both are great mimickers of so many diseases. I'm not going to talk about the other ones, but relevant to this talk, the hypothyroidism can very certainly do it. In case of mixed edema, it can be pretty rapid, like you can develop actually, obviously all the major symptoms, but it can be very subclinical too. And it basically, what hypothyroidism does is that it decreases the mitochondrial enzyme activity, which then results in the reduction of the ATP function, and then poor muscle energy and fatigue happens. So CPK may be elevated, but they can be normal as well. EMG and muscle biopsy are irrelevant, so just the TSH is normal. Treatment is replace the thyroid. You do the thyroid replacement. So you check the TSH and T4, free T4 every 6 to 8 weeks until they are normal. So restoration of the normal thyroid function is the main goal. It may take months to get back to the normal level. Hyperthyroid myopathy, it can be even more subtle. In older patients, in very subclinical hyperthyroidism can also cause myopathy. It may be even the presenting symptoms actually. So here how it is different is, here the patient may have hyperreflexia and fine tremors. So this is what differentiates it from hyperthyroidism. Obviously the TSH is going to determine that too. So risk factors are old age, females, Graves' disease, and rapid correction of hyperthyroidism can sometimes also induce a myopathy. So the treatment is to treat the underlying hyperthyroidism with methimazole, beta blockers, PTU, or radioactive iodine ablation or surgery. Muscle strength is only very gradually going to improve. Always include physical therapy and muscle strengthening. Parathyroid quickly. So the parathyroid hormone, also hyper and hypo both can do it. In hyperparathyroidism, the proximal muscle weakness can happen. It can happen. So one thing very important is to remember in hyperparathyroidism is neuromuscular symptoms. So it will be an older patient with a lot of cognitive issues, confusion, neuropsychiatric problems, depression, fatigue. So this can be one of the tip-offs of that. It could be an underlying hyperparathyroidism problems. Obviously, the serum calcium will be increased, phosphate would be deranged, and PTH level will be abnormal, and vitamin D and renal function should also be checked. So parathyroidectomy typically is the treatment. Now, what about the patients who are an older patient and you cannot actually do the parathyroidectomy? Then it's the medical management that you have to do. You monitor the hydration. Sometimes you can give bisphosphonates as well. So older patient with calcium and phosphate abnormality and neuropsychiatric symptoms and muscle weakness, check parathyroid levels. This is a quick diagram. I'll just, to show the pepper pot appearance of the skull of one of the, it actually is a patient with parathyroid carcinoma actually. Other endocrinopathy, I'm going to skip. Acromegaly can do it. Check the growth hormones, insulin-like growth factors. Surgical resection slowly improves the myopathy. And we know about Cushing disease and Addison's disease, so I will skip that. This is all the stigmata of the Cushing's disease patient, where the increased cortisol, increased insulin, increased glucose, increased sodium, RBC, and moon-like faces, and you know the rest of it. This is another patient with Cushing disease. Electrolyte imbalance. Now, this is important because hypokalemia these are the kind of patients which come out in our clinic too sometime. And we wonder whether they have hypokalemic periodic paralysis. Patients who with exercise or usage of high carbohydrate meals, they can develop episodes of flaccid paralysis. So that is the thing that you should remember. Obviously, in other clinical situation where potassium is very low, there are a lot of other clinical situations. I'm not going to go into their details. You all know about them. But remember also that whenever you're replacing magnesium, always replace, whenever you're replacing potassium, always replace magnesium as well. They go hand in hand. If you are only replacing the potassium and not magnesium, actually the potassium will seep out of the kidney and you will still be in hypokalemic state. So always replace both if they're low. So the ECG is also another tip-off. In acute episodes, you treat with potassium replacement, spironolactone, acetazolamide. In prevention, you give a low carbohydrate diet, which basically triggers the insulin level, which then triggers the hypokalemia. So you actually should be giving a low carbohydrate diet. And you can always give the potassium-rich foods like bananas and then acetazolamide to prevent the attacks. So this is the hypokalemia quick kind of a scheme of things. Inadequate potassium intake, renal loss. If it's a renal loss, I think you're already probably had too much of a dose of renal thing, But remember that potassium to creatinine ratio is greater than 30 milliequivalent is the formula to know that you're losing potassium in the kidneys. And then obviously the gastrointestinal losses like diarrhea and vomiting. There is this U wave. You can remember, I think you all know about the ST segment depression and the U wave. So U wave is one of the ECG criteria of the hypokalemia. Hypophosphatemia quickly. To remember in this case is the refeeding syndrome. In ICU, the refeeding syndrome can happen. So whenever somebody is cachectic, has been in the ICU for longer time and has been malnourished, or is an alcoholic, or is a cancer patient, or is an older patient who have not been nourished well, this can happen. So or a bulimia patient. So when these patients you try to refeed them, means that you try to give them food again, especially high carbohydrate food, they can actually die from the arrhythmias. So remember, it is not as benign. So if you check the potassium level in those, the phosphate level in those patients, if it's very low, you have to make sure that the refeeding should be done in a very nicely programmed way, where you are actually replacing their magnesium, potassium, thiamine, and phosphates together. So refeeding syndrome in all those situations that I told you about can also cause muscle weakness. Mitochondrial myopathy, what are the tip-offs in mitochondrial myopathy? Basically, it's a group of neuromuscular diseases which can cause damage to the mitochondria. And when the damage to the mitochondria happens, it is basically a patient who has an unexplained exercise intolerance. Like during the exercise, they're going to feel as if they are having muscle weakness. And typically, there is also a multi-system involvement, such as cardiac system, neurological system, and endocrine system. Here, the clue is going to be elevated resting or post-exercise. So in resting state, the lactate and pyruvate level can be elevated, but post-exercise, there'll be much more elevation that can happen. Doubling of the numbers can happen. So this is one. And then for the exam taking purposes, ragged red fibers. I think you all have heard about ragged red fibers. I did not actually know what they were before this until I had to investigate. Basically, it's the mitochondria become dysfunctional. When the mitochondria become dysfunctional, overproduction of mitochondria happens. When the overproduction of mitochondria happens, they line up the inside the cell. And this is what gives the ragged red stain on the trichrome Gomori stains. Anyway, I'll quickly skip through. Again, diplopia, ptosis, restricted eye movement, slurs. So neural symptoms as well, along with the muscle symptoms. Genetic testing is the tip-off. You have to check the abnormal DNA of the mitochondria. Again, going through the ragged red fibers. Motor neuron, should I skip through? Then, yeah. So motor neuron disease can do that. Upper motor neuron signs, lower motor neuron signs, different kind of a limb onset, bulbar onset, respiratory onset. Upper motor neuron, everybody knows about. You can actually take a picture if time is less. Main thing to remember is there is no sensory deficit. You can have upper motor neuron signs, lower motor neuron without sensory deficit. Think about motor neuron disease. I'll skip those two. One of these signs is actually pathognomonic. If you can catch this sign, this is one of the signs of a motor neuron disease, which is basically a split hand sign. Split hand sign means for some odd reason, the motor neurons supplying the thinner muscles are going abnormal, whereas the other part is not. Why this happens, nobody knows. But this is one of the very typical signs, if you can see that. GB syndrome, ascending paralysis, post-infectious, so this can happen. Areflexia is the main way to go, main thing of making it a. So remember one thing, that GB syndrome is ascending paralysis and botulism is descending paralysis. And a few points that you can see from there is very important. In this case, one take-home point is don't give steroids. This is an acute phenomena, ascending paralysis, areflexia, and autonomic dysfunction, but don't go give steroids, IV, IG, and plasma exchange. In this disease, which is my last slide, chronic inflammatory demyelinating polyneuropathy, chronic progressive relapsing remitting condition as compared to GB syndrome. The differentiating point between the two is that was an acute situation, post-infectious. This is chronic remitting. In fact, if any GB syndrome looks longer than 8 weeks, then actually you think about, by definition, it becomes CIDP. So in this case, the important thing again in this case is EMG is diagnostic, but in this case you have to give steroids along with IVIG and Plex. So remember these two conditions, the differences between the two. These are the take-home points. I think I've already kind of covered them, so I'll not go into the details. But if you want to take a picture of this slide, this is the summary of the whole talk. Thank you.
Thank you for that insightful talk, sir. Our next keynote speaker is Professor Tsutomu Takeuchi, former president of APLAR and professor of medicine at Keio University School of Medicine, Japan. He is a globally recognized authority in rheumatology with extensive expertise in autoimmune conditions and clinical research.
Today, he will be presenting on Beyond Dryness, Spectrum of Clinical Presentations in Primary Sjögren Syndrome. The session will explore the varied clinical manifestations and enhancing clinicians' ability to recognize and manage this complex autoimmune disease. Please join me in warmly welcome Professor Tsutomu to the stage.
Thank you very much for kind introduction. I'm very honored and very glad to be here to join you, the PSR. This is a patronage program from the APLAR. I am very proud of the support, the PSR from the point of APLAR. So today's my talk is the Sjögren syndrome, now Sjögren disease. So my institution is located in Tokyo as well as Saitama. Looking at here, you can see here in the Tokyo is the population is like 13 million. Maybe the Lahore, the population is similar to Tokyo, and Saitama, that is the 8 million population. Okay, so having said that, I would like to show you about the recent picture of Sjögren syndrome. Everybody knows that the Swedish ophthalmologist Dr. Henrik Sjögren reported this the unique case, a patient with a dry mouth and dry eye with a rheumatoid arthritis in 1930, right here. So after that, this is recognized that the Sjögren syndrome, SS. And then this is the typical sign symptoms, the keratoconjunctivitis, Zika, and this the dry mouth right here. So after description of the Henrik Sjögren, much attention was paid. This is not only a dry mouth, dry eye, but also the systemic manifestation, such as arthritis, muscle pain, fatigue, etc., etc. So this is a milestone in the history of Sjögren, compressing 100 years from 1882 up to 1982. So such as the corticosteroids, the glucocorticoid may be useful for controlling dry eye and dry mouth, and then hydroxychloroquine may be efficacious in patients with Sjögren in terms of the controlling the dryness. And then labial salivary gland, not only maximal gland, may be useful to have a diagnosis of Sjögren syndrome. And also the increased risk of lymphoma is noted in patients with Sjögren. And after this 1982, the detection of anti-Rho SSA and anti-La SSB was widely recognized in the global. So this is the 100-year the history of Sjögren. Now, the Sjögren disease, not Sjögren syndrome, was proposed by Dr. Alan Baer. That was published in 2021 in Arthritis and Rheumatism. Everybody knows now the 2023 International Roma Consensus for the nomenclature of Sjögren's disease. We should say Sjögren disease, not use Sjögren syndrome anymore. For this proposal, maybe the another point is that SJD is the abbreviation of Sjögren disease, not SJS or SS. In addition, associated should be used, not secondary or primary. So this is the most recent nomenclature of Sjögren disease, now not Sjögren syndrome. And you may appreciate here on the right the frequency of Sjögren disease among individuals with another concomitant systemic autoimmune disease. Again, myositis is top, followed by here, and RA, not so high in this publication. So this is the most recent description of Sjögren's disease. However, in the 2018 literature, you may see the primary Sjögren syndrome still. That is the gap between the description of the publication and now the nomenclature is changed. So you may look at these systemic manifestations and classification of primary at this time Sjögren syndrome listed here. This is the most recent ACR EULA classification criteria. You may appreciate here the presence of anti-SSA antibody here. This is a very good clinical marker for diagnosis or classification of Sjögren still. And there are a variety of clinical manifestations here. Dry eye, dry mouth, the glandular symptoms, and constitutional symptoms such as fever, weight loss, and night sweat, as well as the lymphadenopathy, ILD, the renal tubular acidosis, such as the renal involvement, articular, muscular, and peripheral nerve, central nervous system everywhere, in addition to skin. So this disease is not only dry eye, dry mouth, but include a systemic manifestation right here. How about the difference of clinical and immunological features between ethnicity and region and countries? You may appreciate here, that was published in 2017, some 7 years ago. The European USTAR group studying about the Sjögren syndrome at the time, they compared the white, Asian, Hispanic, African American, and other people looking at some a dry eye, abnormal color, or dry mouth, or etc., and etc. So this is the white, mainly coming from the European ancestors, then Asian. In this time, the Devashish Danda, the past present of APLAR, submitted data from India as well as one institution from Japan. So this Asian total number 1,000 is recorded here. And then Hispanic Afro-American. You may appreciate here, dry eye red and dry mouth green. The prevalence of dry mouth, dry eye is lower in Asian, Afro-American compared to the white. How about the immunological features? You may appreciate here again, ANA, the low, that is SSA. So you can appreciate here, particularly low SSA is lower in the white ethnicity compared to Asian, Hispanic, and Afro-American. Again, this is the very interesting data. We should be careful about the selection bias as the site we proposed, the site we enrolled. So speaking about particularly Asian, this only constitute from the Indian patient and Japanese patient, not others. So we need to recruit much more the widely APLAR region. What is the correct feature of clinical picture of Sjögren's disease at this time? So in order to look at much more detail for the Japanese Sjögren patients, we followed up 10 years from the onset, the initial diagnosis of Sjögren's disease up to 10 years. What is the baseline clinical factors, baseline clinical features associated with subsequent 10-year clinical manifestation right here? The hyper IgG at baseline or rheumatoid factor positive at baseline is tightly associated with extraglandular manifestation such as arthritis, muscle weakness, or lung involvement, etc., and etc. Organ involvement is also associated with hyper IgG at baseline or rheumatoid factor at baseline. So we should pay attention at the diagnosis for the seropositivity and the level of IgG, in addition to SSA or other autoantibody profile. And then speaking about the autoantibody status, everybody knows that low SSA, that is detected in 50 to 70%, lower in white, European, the American, the higher in Asian, Hispanic, Afro-American. So in Asian area, this is going up to 80%. And then anti-LA SSB, this is much more specific for the disease of Sjögren's. However, the prevalence is much lower than SSA. Rheumatoid factor, 36 to 74. In addition to 3 major autoantibody detected in Sjögren, we need to pay attention now anti-centromere antibody. Dr. Denton nicely described about anti-centromere antibody in systemic sclerosis. In Sjögren, we can detect this autoantibody up to 27%. So, what about anti-centromere antibody? If you sort the Sjögren's patients into anti-SSA low positive and anti-centromere positive in KU University Sjögren's cohort, up to 500 numbers of the patients. So you may appreciate in this yellow box showing SSA positive and anti-centromere green right here. So Raynaud's and the sclerotactyly. This is the another feature of systemic sclerosis. However, this patient does not associate with the systemic sclerosis. However, this patient with Sjögren having Raynaud's and sclerotactyly were the anti-centromere positive. So dry mouth and dry eye may be a little bit lower, dry eye in anti-centromere, however comparable for dry syndrome. In addition to that, extragrandular symptoms is higher for anti-SSA. So this is the association of SSA and hyper IgG extragrandular involvement, whereas anti-centromere are much more likely to have Raynaud's, sclerotactyly, not so high organ involvement at this time. So when you look at the centromere, speaking about anti-centromere antibody, that is a typical, the positivity is the staining pattern of centromere. However, when you look at the structure of centromere right here, there are several complexes composing the centromere right here. There are several lines of SEMP, SEMP-A, SEMP-B, SEMP-C right here. In addition to SEMP component, there is a very big protein like MIS12C. When you test by using the recombinant autoantigen coming from centromere, you can detect the several percentage of the patient with Sjögren. So, altogether, speaking about anti-centromere antibody positive, in Sjögren is like 15%. The primary estimation is only 5%. So if you combine all of the antibody against the centromere complex is up to 15% now. So having said that, diagnosing Sjögren's disease, that is not enough. We need to identify a subset of the patients who are going to have the organ involvement or extragrandular involvement and autoantibody profiling, as well as the several the baseline IgG and rheumatoid factor, in order to appropriate adjust the treatment. So you may be aware that the glandular disease right here. So you may treat the patient by local treatment for dry eye, local treatment for dry mouth. In addition, we can use some oral medicine for dryness, such as cevimeline or the pilocarpine, to stimulate the salivary gland secretion. So if you have the patient with Sjögren syndrome with dry mouth, you can prescribe either two of these, cevimeline or pilocarpine. That was approved in Japan. Now, this is very cheap treatment, but this is efficacious to control dry mouth. In addition to this, if the patients have extragrandular disease, we need to add some agent, the medicine such as the NSAIDs, low-dose glucocorticoid, hydroxychloroquine, and finally immunosuppressants. So speaking about the target treatment recently, the BAFF receptor intervention such as the inaralumab or the BAFF intervention by berilumab, this is approved in the treatment for systemic lupus erythematodes. This is now tested, not only Sjögren, but also SLE. So you may appreciate here, BAFF is the homotrimer, working not only BAFF receptor, BCMA, TACI, the APLAR or other heterodimer is working also. The berilumab, the blocking BAFF homotrimer. Lanirumab is blocking BAFF receptor. So the two agents are now working the BAFF receptor axis. What about the efficacy of anti-BAFF receptor ranarumab in patients with, in this time, primary Sjögren syndrome, now Sjögren's disease? You may appreciate here, this is the disease activity SDI. This is the patient-reported outcome SPRI. When you look at this, the upper panel shows you the placebo is coming right down here up to 24 weeks. However, ranarumab 300 milligram is significantly coming down disease activity right here. There is also some split between the SPRI here. The stimulated salivary flow is okay in this trial. So this phase 2 trial promoted this is the first large randomized controlled trial that met the primary endpoint in Sjögren syndrome. So after this, we now conducted the phase 3 global clinical trial that is appeared in the ACR next week in Chicago. Another interesting target treatment is for the abatacept. This efficacy and safety of abatacept, T-cell blocker, in active primary Sjögren syndrome was also done in some 3 years ago. The SDI, you may appreciate the SDI and salivary flow in the SPRI right here. The abatacept is orange, the placebo is blue. So there is no big difference between placebo and abatacept in SDI. Also, that is true for SPRI and salivary flow. This clinical trial failed to meet the primary endpoints, so the T-cell target therapy is not working in primary Sjögren syndrome. So this is the list for target treatment. You can hear the systemic, in this time, the primary Sjögren syndrome, abbreviation in this time PSS, now PJD. You can look at this downward. The triangle is BAFF. This is not proved efficacious in the primary endpoint. However, ranarumab, anti-BAFF receptor, now met primary endpoint. So only 2 agents are tested in the large clinical trial so far. So there is no good appropriate target treatment in primary Sjögren's, now Sjögren disease. Maybe BAFF receptor is a good candidate. So based on these data, we are looking at what is the pathogenesis of Sjögren disease again. So this is the initial proposed that was published in 2013, some 12 years ago. At the time, the pathogenesis of Sjögren disease, the role of B cell is highlighted. The B cell coming from the BAFF cytokine is producing the IgG or immune complexes even, or anti-SSA or autoantibody. This is the mainstream of the pathogenesis of Sjögren's at this time. So the BAFF or BAFF receptor target is proposed at this time. However, around the several 10 years or much more time, we initially proposed the role of CD8 T cells for destroying the acinar and ductal epithelial cell in Sjögren syndrome. So this is the simple schematic representation of the role of Sjögren's T cell in the affected salivary glands. CD8 T cell may induce the apoptosis in epithelial cells. This is the initial hypothesis. In addition to CD8, there is a role of the newcomer TFH and TPH to promote the autoantibody production, in addition to BAFF receptor. So coming together, all of the player for the upcoming some 10 years. Now the Sjögren syndrome, Sjögren disease, new pathogenetic model is proposed right here. Not only B cell, in addition to B cell, BAFF receptor axis, maybe interferons and CD8 T cell are coming together to make the complex disease, the Sjögren syndrome. Finally, there are two subsets of Sjögren disease, one with SSA, the another one is anti-centromere. The last month, we published the single-cell spatial multiomics analysis revealed that in the patient's salivary glands, there is two types of the cells are coming together. Patient with anti-SSA, cytotoxic CD8 is coming. Anti-centromere is a CD40PH-TFH, maybe TH17 TGF-beta. So, if you diagnose a patient with Sjögren disease, the pathogenesis behind it, depending on the autoantibody status, may be different, the target may be different, clinical feature may be different. So thank you for your attention. This is my last slide. This is my collaborator at Keio University and Saitama Medical School.
Our heartfelt gratitude to Professor Tsutomu Takeuchi from Japan and the immediate past president of APLAR for his gracious presence and for that enlightening presentation.
With that, our last keynote speaker for this session is Dr. Ahmed Fahim, consultant pulmonologist at New Cross Hospital, Wolverhampton, United Kingdom. Today, he will be presenting on systemic autoimmune rheumatic disease associated ILD, a management update.
This session will provide practical guidance on diagnosing and managing ILD in patients. Please join me in warmly welcoming Dr. Ahmed Fahim to the stage.
Good afternoon. Thanks very much for the invitation. And I would like to keep the presentation on time if I can, because I don't want to keep most people from lunch. And I would like to avoid duplication from Professor Denton's talk, who's very elegantly talked about scleroderma. So I'll start with some classification of interstitial lung disease, because it's very crucial to have a pattern recognition in interstitial lung disease so that you can make an accurate diagnosis, which then leads to accurate management. I'll touch upon some risk factors for ILDs and go through briefly on ACR guidelines, which were published a couple of years back, but my main focus will be on EULAR ERS guidelines, which are recently published and were presented in Amsterdam a couple of weeks back. And I'll finish with a case study of a real patient to demonstrate the challenges we face in this era with SARD-ILDs, and finish with what is on the horizon, and part of it's already been mentioned. At the turn of the century, interstitial lung disease or diffuse parenchymal lung diseases were classified into four main categories. And what we're discussing here today is the ILDs of known cause, which is collagen vascular disease, connective tissue disease, or SARD. But we have a group where there's idiopathic interstitial pneumonias, and they have different acronyms, and I call them alphabet soup because they are named as DIP, AIP, NSIP, RBILD, COP, and lymphocytic interstitial pneumonia, which can be quite difficult and challenging for a non-ILD physician to understand. When we talk about UIP, this is the pattern we deal with, and this is peripheral fibrotic areas and honeycomb cyst formation in a basal and peripheral distribution with temporal and geographical heterogeneity. So if you have this kind of scan, you definitely know that this is definite UIP pattern. And if you don't have honeycombing, then we call it probable UIP, and both of these conditions are linked with connective tissue disease or SARD. This is a pattern which is called non-specific interstitial pneumonia, where you have a homogeneous fibrosis with more ground glass opacities, and you can see the difference in comparison to previous slide. And some of these cases, you have subpleural sparing, which is not particularly the case in this scan. It's a very unfortunate entity because it's called non-specific interstitial pneumonia, but it's a very specific entity. And then we have hypersensitivity pneumonitis pattern. In more recent classification, which is just hot off the press, they have devised this pattern to be bronchiolocentric interstitial pneumonia, which reflects more histopathological domain of this condition. So I think we're going to get more and more confused in terms of the alphabets we're going to use. But at the moment, I'm sticking with hypersensitivity pneumonitis pattern because that is relevant with our case study. And when we have organizing pneumonia, where you have multifocal consolidation, which can be linked with different systemic autoimmune rheumatic diseases. When we look at patients' biopsies, which we don't tend to do these days because the high-resolution CT scans are very accurate, but in subset of patients, we do tend to go for histopathological analysis. And this is a very normal-looking lung with alveoli, which are very good in terms of gas exchange. But when we have fibrosis, the interstitium gets expanded with fibrosis, and you can imagine that fibrosis results in restriction of lungs with poor gas exchange, and patients develop pulmonary hypertension. And the hallmark of fibrosis in UIP is this structure called fibroblastic foci, which release profibrotic mediators such as TGF-beta, collagen-1, and alpha-smooth muscle actin. The gold standard to diagnose patients with ILD is multidisciplinary discussion. And in UK, we have specialist ILD centers where different specialists are involved in discussing patients' clinical history, their lab results, CT scans, and there is the crucial person in that meeting is the radiologist, because they will provide us with the accurate pattern on his radiological grounds. In some cases, we have pathologist input where the biopsies is done, and also rheumatology can be part of that meeting if we are discussing patients with potential systemic autoimmune rheumatic ILDs. I think the components of MDT are expanding day by day, and they're not always present in one particular meeting, but we can tailor it according to the patient needs. There are a number of risk factors which have been identified for SARD-ILDs, and I'll briefly go through some of them. As Professor Denton already alluded to, anti-SCL positivity is a risk factor, and diffuse cutaneous subtype, along with male sex and African American race. If you have early disease, you're more likely to progress to interstitial lung disease. In practice, we see rheumatoid arthritis patients with high CCP and anti-rheumatoid factor positivity is strongly linked with developing ILD, as well as smoking cigarettes, male gender, and high disease activity. When we talk about idiopathic inflammatory myopathies, anti-synthesis syndrome, and the list of those antibodies keep growing at a very fast pace. But I think it's important to mention anti-MDA5, which is associated with the rapidly progressive interstitial lung disease, along with anti-Rho52 positivity. And it's not very much more specific in other connective tissue diseases for risk of ILDs. These are the summary of the guidelines from ACR, published a couple of years back. And if you have suspected patient with SARD who may have increased risk of ILD, the key screening test will be pulmonary function test and high-resolution CT scan. And depending on each individual case, you can decide on the frequency of monitoring. And most cases, 3 to 6 monthly is the interval we go for. And in some other conditions, such as rheumatoid arthritis, and I'm glad to see that they've mentioned Sjögren disease, not Sjögren syndrome, that you can do the 3 to 12 months depending on each patient. So it does vary on the basis of individual patients. And in this slide, you can see this is the conditional recommendation against these tests and a very strong recommendation against surgical lung biopsy in ACR guidance. And all these tests, again, they have recommended against, but they can be used in certain cases if patients are unable to perform PFTs, such as ambulatory walk test. Bronchoscopy is recommended if you want to rule out infection, but the biopsy is not recommended to diagnose interstitial lung disease because of the risk associated with it. Going through the treatment recommendations, what is quite clear in this guidelines is first-line therapy. Mycophenolate is preferred treatment in all SARD-ILDs, along with other immunosuppressants. And there's strong recommendation against using glucocorticoids in systemic sclerosis because of the risk of scleroderma renal crisis. When we talk about patients who have progressed after first-line ILD therapy, then the second-line treatment options are available in most diseases. And you can see nintedanib is recommended in all of these conditions, along with pirfenidone in rheumatoid arthritis, because there was a trial called TRAIL study, which looked at rheumatoid UIP and treatment with pirfenidone, which is other antifibrotic agent. It did not meet the primary endpoint because of the patient numbers were not enough, and it was really challenging because it started recruitment just before COVID. And all these conditions, there is a strong recommendation against long-term glucocorticoids, systemic sclerosis, and long-term glucocorticoids are not indicated in other conditions as well as second-line treatment. Just a quick summary on how to consider management of rapidly progressive ILD if you have severe disease or high risk of MDA5. And by that I mean if patient has presented with ground glass opacities, very significant interstitial lung disease, and very commonly with pneumomediastinum, you should be strongly thinking of anti-MDA5. And if that is the case, you go for IV steroids such as methylprednisolone with 2 additional therapies. If you don't have suspicion of anti-MDA5, it's recommended to use 1 or 2 additional therapies, and rituximab is being used in preference. IV immunoglobulins would be considered if you have very high risk of infection, so you avoid rituximab and cyclophosphamide. We are working on guidelines to develop for UK-specific SARD-ILDs in next 12 to 18 months, and the scope has been published, which is available online. It's a big group of clinicians across the UK, and at the moment we are working through Group 3, which is conventional DMARDs, and you can see a lot of effort is being put through to look at the evidence for all these treatments in SARD-ILDs. What we're looking at, how we should manage underlying SARD and how we balance the underlying management of ILD, because it's a complex combination for both conditions. Are there any anti-rheumatic drugs which are associated with worsening ILD? And how should patients with ILD who are found to have positive antibodies be managed which do not fulfill the criteria for a definite CTD or SARD? And that is the group which is very difficult as nomenclature is confusing. We prefer to avoid the term idiopathic interstitial pneumonia with autoimmune feature for a number of reasons. And we're also looking at other interventions in terms of glucocorticoid, conventional, synthetic DMARDs, and biologic DMARDs, including JAK inhibitors. There's also work to look at antifibrotics, anti-CD20, PPIs, plasma exchange, and as well as stem cell transplant, which has been mentioned. And non-clinical or non-pharmacological treatments are also being looked at. We're also looking at consensus recommendations because we feel the areas such as palliative care, oxygen therapy, and vaccination, they don't have strong evidence base, so you cannot make an evidence-based recommendation, but we will be making some consensus recommendation based on the strength of evidence available. So as I mentioned that this is the hot of the press APLAR guidelines presented in ERS in Amsterdam just 10 days back. They made a task force of specialists across Europe and had 4 groups looking at screening, diagnosis, monitoring, and treatment. They had 25 PICO questions and 28 narrative questions. And what they found was the high-resolution CT scan is the preferred screening tool, and it's a strong recommendation for scleroderma and mixed connective tissue disease, as well as idiopathic myopathies, inflammatory myopathies. There's also recommendation for conditional recommendation in other conditions, but basically we use HRCT as the diagnostic gold standard. Again, it's good to see that they do align with ACR recommendations that BAL or bronchoalveolar lavage and biopsy should not be used for diagnosis. However, we can use this bronchoalveolar lavage, rule out infection or diagnosed some type of malignancy. And that is clinical practice we do in the UK. They have made recommendation in terms of monitoring and the frequency of different investigations in scleroderma is based on the risk and how is this, what is the duration of the disease. So if you have disease duration less than 3 to 5 years, you're more likely to develop ILD, so you should monitoring these patients more closely as compared to if the duration of disease is longer. And in rheumatoid arthritis, these recommendations are fairly similar, but you can see the risk goes slightly different in terms of disease duration. So you are likely to develop interstitial lung disease for a longer period if you have scleroderma as compared to rheumatoid arthritis. And this high-resolution CT has been recommended to be repeated annually in high-risk patients and every 2 years in low-risk patients. When they looked at the treatment recommendations, they looked at if immunosuppressive therapies versus control should be used for treatment of CTD-ILD. They stick with the term of CTD-ILD rather than SARD. Should antifibrotics be used instead of controls? And should combination therapy versus control be used in treatment of CTD-ILD? So I think this is a very important slide in terms of the value of tocilizumab in early diffuse systemic sclerosis. If you have synovitis, signs of inflammation, then tocilizumab has been recommended with strong recommendation. And that's the only strong recommendation which has come for scleroderma ILD. And if you have fibrosis extent more than 10%, nintedanib is recommended. Our patients have high risk of progression than nintedanib and MMF, which has been shown in Census trial would be quite an appropriate treatment. And combination of immunosuppressant will be considered, specifically in severe multi-organ involvement. Rheumatoid arthritis, they've recommended immunosuppressive treatment and also combination of immunosuppression if you have severe or progressive ILD. If you have a UIP pattern on CT in rheumatoid arthritis, then pirfenidone has been recommended as conditionally. But I don't think it is likely to be approved in UK. But internationally, following this publication, I think we'll see more interest of pirfenidone to be studied in rheumatoid arthritis ILD. In inflammatory myopathy treatment, this immunosuppression is strongly recommended, including corticosteroids, tacrolimus, and rituximab. And the rest of the treatments are fairly similar as in scleroderma and rheumatoid arthritis. They also then group the other ILDs in one main group, and the combination treatment is recommended with high risk of progression, or you would start looking at rituximab and cyclophosphamide. In my experience, rituximab is being used much more commonly as compared to cyclophosphamide since the recital study. So I thought I will make a comparison of ACR versus EULAR in terms of scleroderma ILD. And you can see that ACR recommended first line MMF, tocilizumab, and rituximab. And if you see EULAR, they've recommended MMF and tocilizumab, particularly early diffuse with inflammation. The additional treatment in ACR demonstrated cyclophosphamide, azathioprine, and nintedanib, and strongly against corticosteroids. And that goes with EULAR as well, that nintedanib, if you have fibrosis more than 10%, or cyclo versus rituximab. So it is quite important and reassuring to see that two main group of recommendations from different organizations are coming with similar conclusion. And they're strongly in favor of mycophenolate and conditionally in favor in the bottom drugs. And I think the research recommendation would be pirfenidone versus pirfenidone and mycophenolate, which will be interesting to see in the near future. This was a review from our paper published recently, and we talked about pragmatic management. If you have predominant inflammatory pattern, you go for immunosuppression. If you have mixed fibrotic and inflammatory phenotype, then combination therapy will be important. And if you have predominant fibrotic pattern, the question is, do they respond to anti-inflammatory? But in practice, I think we would need to go for anti-inflammatory and anti-fibrotic combination. because they have strong immunosuppressive and immune-mediated pathogenesis in this condition. So I'd like to go through quickly on a case of 37-year-old lady presented to our institution in 2018 with breathlessness for 5 years, never smoked. She kept birds 5 years back and had ANA positive and avian presbyopia positive with mildly positive rheumatoid arthritis factor. This was a CT scan for some reason 5 years back, which showed normal lungs. And in 5 years, you can see it developed interstitial lung disease with reticulation and reduced lung volumes. It's not a typical UIP pattern, but certainly showing interstitial lung disease. And she was diagnosed with hypersensitivity pneumonitis on radiological grounds, restrictive spirometry, and gas transfer of 48%, and started with treatment of steroids as a trial, but could not tolerate. So we underwent a wax biopsy demonstrating lymphocytic infiltrates in peribronchovascular fibrosis, but no granulomas. They were non-specific features, but were consistent with probable hypersensitivity pneumonitis. So she was commenced on azathioprine and additional immunosuppression as steroids were not tolerated. And we further discussed the case in our specialist interstitial lung disease, and scans were compared showing demonstration of progression since 2019. So we evaluated her in combined clinic with rheumatology and repeated her immunology screen, which showed anti-PM-SCL75 antibody with weak positive ANA. And it was felt that she most likely has underlying CTD with progressive pulmonary fibrosis. So she was commenced on nintedanib as antifibrotic agent along with azathioprine, and we referred her to lung transplant because she was only 38 or 39 at the time. Her BMI was too high to consider for transplant, and back in 2023, she had further admission with acute exacerbation of ILD. And she continued on nintedanib and azathioprine, commenced her oxygen at this stage, and transplant referral was reviewed again. And we reviewed again in the combined clinic and considered intensifying immunosuppression and sought another second opinion from Regional University Hospital. And she was commenced on rituximab with 1 gram, 2 weeks apart with methylprednisolone. Unfortunately, she reacted to cotrimoxazole and developed significant pulmonary hypertension with PA pressure of 65 millimeter mercury. She was sent to pulmonary vascular unit in Sheffield. They started her on sildenafil and macitentan. And pH, pulmonary hypertension was confirmed on right heart catheter, so she is awaiting a lung transplant. I'm not going to go through this in detail, but this is a snapshot of trials in interstitial lung disease with grade A evidence, rituximab, MMF, cyclophosphamide, and nintedanib, and tocilizumab is demonstrating grade B evidence. And this is a snapshot of the trials in scleroderma, which have been discussed already. I think what is missing in this is the inbuilt trial, which showed demonstration of positive results of nintedanib in progressive pulmonary fibrosis. We're using remote monitoring of ILD in SARD-ILDs, and it is becoming very common, and it has become a practice in Europe to identify early deterioration in patients with ILD, and it correlates very well with home versus hospital spirometry. So I think it's very important we consider this technique in monitoring patients with SARD-ILD and should be integrated into routine ILD clinical workflows. We presented this paper and this work at recent Congress in Amsterdam, demonstrating that 20% of patients who progress with interstitial lung disease can be captured with remote spirometry earlier than the usual practice in 3 to 6 month lung function tests. And this is a quick snapshot what we see in the remote spirometry readings, which are sent through an app to the portal, and you can see the stability of patients' FEV1, FVC, which can be reviewed every week or every 2 weeks. And this is a snapshot over 6 months. You can see the variability in FVC in patients who are monitoring at home with home spirometer. I'd like to finish on the what is coming on horizon in SARD-ILDs. Fibroneer program demonstrated that nerandomilast is beneficial in patients with progressive pulmonary fibrosis and IPF, and phosphodiesterase 4B inhibitor has been just approved by FDA. We are looking at MIST trial, which is inhaled pirfenidone or nintedanib. We are part of that international study, which is looking at nebulized pirfenidone, which will be exciting to see as it will have less systemic side effects. Conquest of Scleroderma Research Foundation is looking at collaborative scleroderma research, 125 sites worldwide, and also there is trial of GC inhibitor, which is in phase 2, along with CAR therapy, in, as Professor Denton alluded to. So I would like to conclude that SARD-ILD is associated with significant morbidity and mortality, and ILD is one of the main risk factors for mortality in systemic autoimmune rheumatic ILDs. It's crucial to identify ILD early so that we can commence patient treatment appropriately, and I think it's crucial to have collaboration between respiratory and ILD and rheumatology disciplines to manage this complex group of patients. Immunosuppression along with antifibrotic therapies are the mainstay of treatment option to manage comorbidities, and I think it's fascinating to see such a great group of clinicians in this meeting, and international collaboration to understand the patterns of ILD and treatment in different healthcare systems will be important to improve care globally. Thank you very much.
Thank you, Dr. Ahmed Fahim, for that valuable presentation. We now transition into the Q&A session.
We request our chairpersons to kindly oversee the discussion, moderate the flow of questions, and help channel the audience's queries to the speakers.
Thank you very much to all the speakers and the audience for paying attention and sending us lots of questions. The first question is to our last speaker, Dr. Ahmed, from Dr. Saira at Fuji Foundation. Is there any role of JAK inhibitor in patients with rapidly progressive ILD but negative for MDA5 in myositis associated ILD?
I think baricitinib has been trialed and been suggested in the test guidelines. So if you have high risk of infection, then JAK inhibitor has a role in anti-MDA5 and rapidly progressive ILD. But I have to say, personally, I've not had any experience of this so far. What was the second question, sir?
That was the question.
Okay.
What are your thoughts on UPA?
I'm not sure if Professor Denton has more experience of JAK inhibition.
I'll give a short answer because of the time. So no is the answer. Not in ILD.
Sorry. So the next question is for Professor Chris Denton by Dr. Durkhani, Shifa International. He has presented a case presentation of a patient who presented with puffy, swollen, painful hands, who is ANA positive and anti-SCL70, which is strongly positive. His baseline echo, cardio, X-ray chest, all other investigations are normal. Do I start with the MMF or methotrexate or an IL-6 blocker?
So that's a great question. It's very topical. Another challenge is, can you intervene in systemic sclerosis much earlier? So there's a concept of VDOS, very early diagnosis of systemic sclerosis, which probably covers that type of patient. I think at the moment there's no strong recommendation, but personally in clinical practice, we would consider carefully discussing with the patient, but I think those patients should go on to a disease-modifying drug. The choice we would have in our clinic would be between hydroxychloroquine or mycophenolate mofetil, but the main thing is to discuss risk and benefit with the patients. But hopefully in the future, and I know they're planned, some trials will actually test whether it really makes a difference.
So another question for Dr. Shakaib. By Dr. Muhammad, and he has asked that how to stop or restart statins once we realize things are getting worse. How to restart once things get better.
They get worse? So I think what they basically mean is when to stop the treatment when the patient is very symptomatic. So obviously you're going to stop it if you feel that the patient has symptoms. That's the reason we're going to stop it. So if it's just like a non-antibody induced phenomena, then you have to obviously, and the symptoms are very mild, you just stop it and observe it. And symptoms will go away. If it is a nocebo effect that we talked about, or if it's a very mild effect, you can always restart with those mild kind of statins that we talked about, the pravastatin or rosuvastatin, and also can do the alternate day therapy that we talked about. But if it is like a rhabdo, then probably I will not re-challenge them. And when to restart is obviously when the patient is asymptomatic. Now we do have other mode of action drugs though. So remember that we have those PCSK9 inhibitors. We are producing more and more those kind of drugs, which in combination can very reliably reduce the LDLs. But as I said, like 90% of the patients who are re-challenged in milder symptoms do very well. Does that clarify?
Yes, thank you very much. Sure. Thank you, Shakaib. Next is Professor Takeuchi. The question has been asked by Dr. Saira, who is a postgraduate trainee at Fauji Foundation Hospital. And she's asked to elaborate, please highlight the role of rituximab in Sjögren's disease.
Which?
The role of rituximab in Sjögren's disease.
Okay. So the clinical trial by using rituximab failed to achieve the primary endpoint. So at this time, there is no proof that rituximab is working in primary Sjögren's syndrome, Sjögren's disease, unfortunately. So, no.
That's all. Any more questions?
Yeah, just one final question to Dr. Shakaib again. There was another question for Professor Denton about the role of JAKs because JAKs are easily available here in Pakistan. They're not so expensive. That's why we have the number of questions on JAKs. And would you just elaborate on a very short no as to why would you say that there is not much evidence?
So the longer answer would be, of course, the JAKs are very attractive as a treatment, and seeing the results for tocilizumab working on the same pathways and our experience in rheumatology in general. So there is a lot of interest in using the JAK inhibitors. We are using them occasionally in our patients. In the UK, access really depends on having an overlap diagnosis with some arthritis, for example, but we have had some positive experiences. I think, again, the challenge will be whether or not they are as effective as drugs like tocilizumab and, of course, safety. But they're very exciting. The trials that have been done have suggested certainly sort of molecular effects, benefits in skin biopsies, etc., but not so much clinical benefit so far for skin and for lung. But I think they will be used more.
Thank you. And the final question to Dr. Shakaib Qureshi again. This is from a fourth-year medical student, Zainab Fatima, and she asked that there is a patient with inflammatory myopathy and on steroid therapy, and you have diagnosed that the myopathy is steroid-induced. And after tapering the steroid, what other options do you have to improve the patient's condition?
Yeah. So I think that's exactly what I discussed about when we have this dilemma of treating the patients who have steroid myopathy. So obviously, first of all, I think the most important thing for the students at least is to remember that that we discussed about the fluorinated versus non-fluorinated steroids. So I think the dexamethasone usage I've seen more in Pakistan than I've seen abroad. So try first of all to refrain from using dexamethasone. The tapering will be very tough too, typically. So try to first go with the shorter steroids like such as prednisone or prednisolone or IV solimedrol in order to prevent such a phenomena. The second thing is when you are giving steroids, then you have to make sure that you also have a tapering schedule in your mind according to the patient's clinical symptoms. One thing I remember in myositis, in my previous talks, I've always talked about is always have physical therapy on board. Many people think that with myositis, even early stage, you give them rest. Resting is not allowed. You have to start the physical therapy from the get-go so that you preserve that muscle mass and muscle strength. Because in steroids also, it's basically the fibrosis of the muscles that happen and the gradual destruction of the muscles. And it's basically muscle atrophy. So when you're really cornered, let's say now you've given the steroids and you have not been able to taper it, and now you have a steroid myopathy, but an active disease, I think that's what the question is. Then what next to do? I think obviously then there is the underlying role of the immunosuppression drugs that you are now going to rely. In fact, the whole goal in all the rheumatology treatment is to try to get rid of the steroids and give the immunosuppressions very early, so that we don't have the short-term or the long-term side effects of steroids. So I think the underlying phenotype is very important. As my second slide mentioned about the bunch of antibodies, I strongly recommend all the students to almost memorize those antibodies, because in the coming years, you're definitely going to have a lot of treatment modalities tailored around them. I've almost seen almost all of those phenotypes, even in Pakistan. And if you're lucky enough to get hold of a good myositis lab that you can do, I found all different kind of phenotypes here. Anti-Q, anti-ROLA related, anti-RO52 related disease, like you name it. Then your next scheme of action is going to be based on what the patient's underlying problem is. If it is just an MI2 related dermatomyositis, you can probably just taper off steroids and you'll be fine. But if you're cornered with an MDA5 kind of a treatment, then you know that it's going to be rituximab and cyclophosphamide kind of a deal. So it all depends upon what an underlying clinical condition you're dealing with. If it's related to myositis, obviously steroids are used for so many other purposes too.
Thank you very much. We would ask our worthy chairman, Professor Kamran Chima, and before that, we have another Dr. Sabah. And
so again, the question is addressed to Professor Chris Denton from Dr. Fatma. Is there any cutoff value of modified Rodnan score for starting MMF in systemic sclerosis?
So I think the question was, is there a threshold of modified Rodnan skin score for starting MMF? So I think in clinical practice, we wouldn't say so, because the key thing, as I showed in diffuse scleroderma, is to start early, so you wouldn't want to wait for accumulative damage. So we would say, if our recommendations would be, if the patient's classified to diffuse scleroderma, whatever their skin score, and it may be low, such as 10, which is a mild skin, still we would start it. So no minimum threshold in clinical practice. Of course, in all of the clinical trials, they have minimal thresholds of 10 or 15, but in practice, no.
Another question again from you, from Dr. Saira. As skin scores become static over the years in scleroderma, so when we should stop immunosuppressants in such patients which were specifically prescribed for skin thickness?
Yeah. So it's a really great question, and something I think the scleroderma specialists have learned over a number of years, that in fact you do need to continue with your immunosuppression for several years. When we started to use MMF, we used to think about using for 3 years and then trying to taper it. As we saw, about a third of patients really flare either in the skin or the lung when you taper it. So we now say 5 to 7 years of MMF is our standard approach. I think you could say the same for other immunosuppressions. Absolutely try to minimize or avoid steroid use long term, but for MMF, longer term. But the key thing is when you do start to taper, to do it slowly. You can do that. So we would normally drop by maybe 500 milligrams and watch for 6 months, and then to bring it down slowly over 18 months. And then if you do see a flare, you can reintroduce it. So 5 to 7 years would be our minimum duration.
Thank you.
Thank you. This marks the end of the Q&A session.
I think we're just going to ask for comments from Professor Fahim Malik Sahab and then Kamran Chima Sahab for you.
Thank you so much. An extraordinary session. I really enjoyed, and it was a very wonderful talk by every speaker. Over a period of a decade or so, what we are seeing, there is significant change in approach of a pulmonologist specifically, and it's a now multidisciplinary team. In ILD, whenever we look for the literature, it's changing not over the years, over a month. There is always a new guideline which give us a new insight, and when to switch over these drug from anti-inflammatory to anti-fibrotic is really challenging. And every speaker talked very well about the disease and the modification, and I really like the talk. Thank you so very much for this.
I'd like to thank our worthy visiting speakers, Professor Christopher Denton from the Royal Free, Professor Tom Takeuchi from Keio University, Dr. Fahim from New Cross, Wolverhampton, and Dr. Shakaib, my neighbor from Tech Society, for their very enlightening talks. They were on time, and the talks were very, very informative. And we learned that the survival of scleroderma improved between 1990 and 2000, thanks to the data of Professor Denton, from 70% to 84%, which is amazing. And these are complex diseases, and the treatments have only modest benefit, and the treatments are highly toxic. So, and the diseases tend to spread rapidly. So who to treat, when not to treat, when are you getting treatment-related side effects? This group of diseases always keeps us on our toes. And to make things more interesting, there's a new anti-fibrotic drug recently showed promising results in interstitial lung disease. Literature as an add-on to pirfenidone, and we will hear about it. Nerandomilast, which is a PDE4 selective inhibitor. And for pulmonary hypertension, only 2 weeks ago, there was data with the new activin signaling pathway inhibitor, sotatercept, which is an injection every 3 weeks in controlling pulmonary hypertension. In pulmonary hypertension, the treatments, I'm just bringing it up because it's common in connective tissue patients to sometimes have it. The treatments are not as toxic. You'll have hemodynamic side effects you can stop. But in ILD, the treatments are toxic in an environment like Pakistan, where there's a lot of chronic granulomatous diseases in the background. I sometimes am the one who's stopping the treatments, because when I see the patients who are started on treatment, because there's a lot of enthusiasm to use newer therapies, I sometimes am unfortunately the one to stop them, because we have a lot of granulomatous infections and a lot of hypersensitivity pneumonitis. If Professor Denton and Tom went to inner city, they'd probably see that every rooftop has pigeons. So there's a lot of people living with all those birds. So there's a lot of ILD that is not CTD related. That is HP, as Dr. Amin showed, with a patient who had one bird, and you take Amin to the inner city and you'll see hundreds of birds in every house. So with that, I would like to thank everyone for their presence, for their wonderful questions, and for their patience. Thank you.
Thank you to our speakers in the audience for such a thoughtful exchange. Since we are running short on time, I would like to request our worthy chairs, Professor Kamran Chima, Professor Wajad Aziz, Professor Javed Malik, Co-Chair Dr. Sabah Saif, and our panelist, Dr. Irfan Malik, to please come forward and present a token of appreciation to our speakers.
First up, we have Professor Chris Denton. I request you to please come on stage to receive your souvenir. Next up, we have Dr. Shakaib. Please receive your souvenir.
For those who are leaving, the lunch is in Grand Ballroom B, courtesy of Hilton Pharma.
I request Dr. Ahmed Fahim to receive his souvenir. Dr. Ahmed Fahim, please join us on stage.
I would like.
I now request Dr. Tsutomu Takeuchi to receive his souvenir. I request Dr. Ahmed Said, convener and president of Pakistan Society of Rheumatology, to say a few words. I now request our jury to present all chairs a token of appreciation to commend their efforts. Professor Kamran Cheema, Dr. Javed Malik, Dr. Wajahat Aziz, lastly we have Dr. Irfan Malik. Lastly, we have Dr. Sabah Saif.
Ladies and gentlemen, we will now be taking a break for lunch and Zuhur prayers. The lunch is being served in the Grand Ballroom B, courtesy of Hilton Pharma. Please make sure to rejoin us promptly after the break on time. Thank you.
We would all appreciate if everybody can be here by 2:15.